hello, and good morning, and welcome to Coffee with the Coder. This is a new series with AQIQ and Paula Digby and our other expert coders. We are eager to get started and share with you what's going on, and some interesting questions have come in. I'm going to turn it right over to Paula. Paula?
Thanks, Pam, and good morning, everyone, or good day if you're listening at a later time. We're so glad you joined us today or made the decision to listen to us. As we indicated earlier, this is a new series, and what we're really doing is talking about in our next 10 to 15 minutes only, we're talking about some of those important things to us in the HIM profession. If there are coding questions, provided they don't require extensive research, and those we can always start and call you back, talk about things that are up and coming in our industry. To start out with today, there were a few questions sent in, and one from Donna. She's asking, this is really more a case management question, but still revenue cycle related. Do you know the latest on the moon, that is MOON? I've not been able to find a final form nor implementation date. So Donna, let me give you the specific link at CMS in order to give you all the information about the moon, and then I'll tell you what it says also. That is https://Medicare//Medicare-general-information/B as in boy, N as in Nancy, I as in ice/index.html. And if you need that, we can certainly send that out to you. So email us at, or you can email Pam actually at pamproctor@aq-iq.com, and that dash is actually a hyphen, and she'll get that right over to you. We'll also have it on the AQIQ website associated with this call. So first of all, CMS says the moon is a standardized notice to inform beneficiaries, including health plan enrollees, that they are an outpatient receiving observation services and are not an inpatient of a hospital or critical access hospital. This is directly off the CMS site that I've directed you to. The moon is mandated by the Federal Notice of Observation Treatment and Implication for Care Eligibility Act, or notice, was passed back on 2015. The Notice Act requires all hospitals and critical access hospitals to provide written and oral notification under specified guidelines. Medicare outpatient observation notice and accompanying form instructions are available in the downloads section on the link that I provided for you. And the manual instructions will be available, CMS says, in the coming weeks. All hospitals and critical access hospitals are required to provide the moon beginning not later than March 8, 2017. So they've given us a date, a drop-dead date for providing the moon, but they really haven't given us the complete rules that we are going to abide by as far as filling out the form, if you will. So there's more to come from CMS. So one of the things that I forgot to say as we started off today is, I hope you all have your cup of coffee sitting there. My husband was nice enough. I'm actually in my home office today, and my husband was nice enough this morning. He didn't even know we had a meeting this morning on Coffee with the Coder, but he popped out to the local coffee shop and got me a large cup of warm tea. I'm not necessarily a coffee drinker unless I'm super cold, but he did get me a nice cup of warm tea. So I hope you are sitting there with your cup of coffee or cup of tea or something nice and hot to drink, and then thinking about all these questions that we're answering, as well as thinking about some questions that you might want us to answer, or just a conversation that you want to have, and we can certainly have conversations going forward. We have lots planned for you on Coffee with a Coder, as well as some guest speakers coming forward in the future months as well. Now let's jump to Carla's question. Carla had a question about inpatient rehab facility coding. She says, is it appropriate to code encephalopathy from a consult when the attending has documented the patient is alert and oriented ×3 and does not mention the condition? The patient did have encephalopathy while they were in the acute hospital. Well, here, Carla, here's what I would do in this situation. I would query the rehabilitation physician to validate the current condition. In rehab or in an IRF setting, that's the inpatient rehab facility setting, the attending physician is responsible for both the medical and functional. The rehab physician is typically the attending, but in some situations you have an attending that is a medical physician. But CMS regulations actually say that the rehabilitation physician is responsible for the medical and functional. So with that said, I would query that rehab physician and or the attending to get clarification. And I do know there is some question when you have the medical physician being the attending. It can cause some issues related to the documentation, but query would be what I would do. And in our final question, I think for today, well, actually we did have one other, but in our question related to a coding situation, it was Deborah asked, and it's also an inpatient rehab facility coding question. She says, I get an initial admission coding sheet with codes for the IRF-PI. I then get a final discharge coding for the UB. The codes are different for the IRF-PI and the UB. I need to know how to distinguish the codes for the UB versus the IRF-PI. Wow, this is a big question. Actually, Deborah, there needs to be open communication with the coder because it would be very difficult for a non-coder, and that is provided that there is a non-coder taking those codes, it's what it sounded like, taking those codes from what the coder has assigned for the IRF-PI versus UB and giving you a different coding summary at admission versus discharge. It would be difficult for someone who is a non-coder to understand all the coding nuances. Some are pretty straightforward, and you can see, when you need to change codes on discharge because something got a little bit more specific. But that is not always the case. Sometimes, it requires 2 or 3 codes that the coder is very aware of. But when those final codes are assigned, the person who is translating that information to the IRF-PI may or may not understand what goes on the IRF-PI. So that open communication between the coder and the PPS staff or the IRF-PI member who is entering the IRF-PI information is very important. The other thing that could occur inside your offices is you could have, there could be a process where the coder would assign the codes for the IRF-PI only at admission and then for the IRF-PI only at discharge, and then separately code for the UB04 or change those codes for the UB04 following to finalize the claim. So they're actually providing only IRF-PI codes to the PPS or CMG coordinator or to the IRF staff member who is entering that information. So, and then the last question really was an individual who wanted to be included in our training, and absolutely, if you'll enter and get in on our mailing list at aq-iq.com, enter and create an account. You will get all of the information as to when we do Coffee with the Coder, as well as when we do our training sessions in addition. So we're bumping up against our 10 minutes. I want to thank you all for joining us today and being a part of AQIQ and letting us bend your ear a few minutes and have some coffee with us. Thank you so much, and have a great day.
Thank you, Paula. We look forward to hearing all of you next time, which will be January the 2nd for the next episode. Send in your questions at aq-iq.com.